Veterinary Eye Talk, let's go!
All right, hello everyone. Welcome back to another episode of Veterinary Eye Talk. I'm Dr. Ben Reynolds, joined as always by my former colleague and superstar co-specialist and co-host, Dr. Paul McCarthy. How you going, mate?
Yeah, not too bad. It's been a couple of weeks, so I feel like I need to apologize on my end as I've been on holidays. And my partner, Em, actually pointed out to me that the thing to do there is to pre-record some episodes. But Ben and I are authentic, you know. We don't want to be, you know, having these pre-recorded change of shirts sort of things. We want to give you the real deal. But no, I've been traveling the US, as Ben knows. Fortunately, got to pop in and see his hospital in Vegas, which was pretty cool. Got the grand tour. But otherwise I've been doing well. About to head home. How are you going, Ben? What's been new for you?
Nothing too exciting to report on my end, mate. Just much of the same. Working that 9 to 5. Getting married in a month, so that's pretty exciting. So I'll be back to Australia in not too long. I can see it looks like you stopped in Hawaii on your way home, or Tahiti, or somewhere similar from the background.
Yeah. It's actually no. I'm currently in Sedona, in Arizona. So this is a lot of people don't know this about Sedona. Common misconception that it's a desert. It's a bit of a tropical paradise. I've been hitting the beach. No, actually, I genuinely am in Sedona at the moment. And if anyone is listening and likes the outdoors and likes hiking, highly recommend Sedona. You can also get your chakra checked, which I have not done. I don't know what a chakra is.
Mate, you'd spend all day there trying to find yours, I suspect.
Yeah. No, so what are we talking about today, Ben? We got a pretty simple but a really important one, I think. I shouldn't say simple, just a very common one that we're going to try and keep really simple, I should say. But again, a super, super important one, and one that I'll start off by saying is there might be some variation, and Ben and I will talk about a bit of the variation, but between country, depending on where you're listening. So Ben's going to, and this will make a lot more sense when he gives us the topic, but Ben's going to be the forefront for the US or North America sort of side of things, and I'll talk about Australia, which Ben but it gives me something to do. So Ben, why don't you intro our topic for tonight?
Yeah, perfect. So this is something Paul and I were brainstorming on what to have the grand return episode on, and this is certainly something that I feel like I have lots of conversations with the general practice community and referring vet community, which is just like, hey, when should I use what antibiotics topically for corneal ulcers? So, you know, when do we reach for one bottle versus the other bottle? And as Paul's touching on, there's lots of local geographic availability differences. Possibly, one might expect that there's, local differences with prescribing practices based on what vet schools have taught you and so on. And so we'll talk on all of that, and I guess try and come up with a bit of a framework that, depending on what you have available, what antibiotics you can reach for different types of ulcers. I guess for me, the most logical place to start is with superficial ulcers that do not appear infected or do not appear like they're melting. And we could probably talk about dog versus cats, and if we pick different things, and if we do, why. But yeah, for our Southern Hemisphere audience, Paul, if you are confronted with a superficial ulcer that's only 2 or 3 days old, you got no suspicion that it's non-healing in a dog, what antibiotics are you reaching for and why?
So I think I'll start by, and there's one antibiotic that I can think of that this sort of covers that I've got a bit of a gripe with. But I'm going to start by saying that I'm always reaching, in this case, and almost, and most of the time, in general with corneal ulcers, I'm always reaching for a topical antibiotic. So I'll start there. I think Ben can probably think about the antibiotic that I sometimes see prescribed that, look, I know there are some ophthalmologists out there who recommend prescribing this antibiotic.
All right, everyone, clear your next 30 minutes. I know where this is going.
Yeah, no. I'm not. I'm going to stay away from it. I'll stay away from it. But okay.
No,
I'm just going
to touch on it. It's great. Touch on it.
So sometimes I see the use of doxycycline, which has sort of become, in my mind, the poster-child eye antibiotic. I don't exactly know why. There's discussion about, its what we call MMP properties. My issue is that the concentrations required to actually inhibit the MMPs are probably not going to make it, or there is actually a study out there from a while ago by Dr. Sean Collins, I believe it was. Sean, if you're listening, you better be. I'm going to quiz you on this, where he found that they didn't, with the standard dose, reach that anti-MMP effect in the tear film. And so if that's the reason you're using it for, then my question is, are you even getting the correct concentration there? And then the next point I guess I would make is, if you have the option from a stewardship perspective, an antimicrobial stewardship perspective, to put something in topically, then I just always think you should. Because, if you give doxycycline orally, you're treating the whole animal. That's all I'll say about it.
No, I think it's a good point. Like, I think it's a good point, even to frame, like, yeah, we are so blessed, and I guess I take for granted as well. But, the eye is one of the few organs that you can deliver a really high concentration of any medication, but this specific topic, antibiotics, locally to exactly where it's needed. In the cornea is the most superficial structure of the eye. And so, and we're talking about specifically ulcers, where the epithelium, one of the barriers of drug penetration, is missing. Like, really, this is like the perfect storm of how to deliver high concentrations of drugs, right where they're required and without needing to systemically medicate an animal. So, no, I think your rant, and you've showed a lot of restraint, mate. So this is the shortest edition of it I've seen. So congratulations. But I think it's justified. I think it's important, and yeah, I think it's fun to rile you up about it. But it's it is important. And I agree with you for what it's worth.
So with all that covered, the antibiotic that you can reach for, and I'll preface this by saying, as Ben said before, if you cut to this point or something, this is Southern Hemisphere, because I know that North Americans are probably going to hear this and panic, or think that we're absolutely crazy in Australia, which,
and we are,
I promise
we are,
but for other reasons. But it's actually chloramphenicol. Now, chloramphenicol has got a good broad spectrum. It's readily accessible topically in Australia, and it's very cost effective, and it'll cover a good portion of those bugs that we're concerned about prophylactically. And this is a non-infected ulcer I'm talking about.
Yeah.
The other,
just for the benefit of our listeners, and what is the benefit of treating a non-infected ulcer with antibiotics?
Really good point. The benefit is it's prophylactic, preventing or reducing the risk of infection. And if you have a non-infected ulcer that's not getting better, and this will come down to more of a general ulcer talk, but one of the key things that was said to me early on is, if it's a non-infected ulcer and it's not resolving, change your diagnosis, don't change your antibiotic. i.e., there's something else there that's driving that ulcer. Okay? Because unless there's an infection there, antibiotics don't heal ulcers as far as I'm aware. At least there might be some really unique circumstance out there other than infection that I'm unaware of, but for your day-to-day, so with that in mind, one good broad spectrum antibiotic such as chloramphenicol, or in Australia we have a couple of different triple antibiotic combinations which achieve the same thing or a similar thing. And then in terms of whether you apply that in the form of an ointment or an eye drop, personally, I don't really have strong opinions about either. All I would say is I use both. Some owners find it a lot easier getting an ointment into the eye, whereas others find drops a lot easier. All I would say on that is I tend to adjust the frequency at which I apply the antibiotics based on whether it's a drop or an ointment. And that is, I will tell the owners to apply the drop more frequently throughout the day when compared to an ointment. Usually with an ointment, I'll do that, let's say BID, whereas a drop might be, 4 times a day.
So, Paul, you're telling me that you're touching that heinous material called chloramphenicol, and yet you're still able to produce red blood cells. You haven't died of aplastic anemia. Oh my
It's crazy. Word. It's crazy. Actually, we had a visiting very, very, very prominent ophthalmologist, veterinary ophthalmologist, who's done a lot of really amazing work, who was visiting Australia and popped into the clinic. And he was surprised to see our use of topical chloramphenicol so liberally. In Australia, it's actually available as an over-the-counter medication. So, you could go to the chemist and get it over the counter. I originally thought that, and we won't get too much into this, but I was talking to I actually saw, this was quite strange. I can't promise I'll come back from my digression, but I had a wildlife carer who came in with a possum just before I came overseas. I immediately recognized her, and she was actually my pediatrician that I'd been seeing as a kid. It was it was just so
wow.
funny. Yeah.
Wow.
And she remembered exactly who I was. She remembered my frequent ear infections when I was a child. I mean, I would have seen her for 12 years. And she does wires work. She's a lovely lady and still practicing family medicine. And I actually spoke to her about the chloramphenicol, I guess, the concerns around chloramphenicol. And she told me that when she started, and this is something I don't know much about, but when she started her practicing career as a doctor, there was this phenomenon or this disease that they saw that they called, she said it was gray or blue baby syndrome. And that was caused by use of chloramphenicol, this anemia, I believe. I don't know. I won't go too much into it, but that's why the regulations apparently came out. I don't know the specifics as to why in North America it's remained, I imagine, less accessible, heavily restricted versus Australia. But as last I checked, I don't have anemia. But yeah, no, that's what we have available. Now, if you don't want to use chloramphenicol for whatever reason, absolutely fine. There are a number of triple antibiotic ointments that are available as well in Australia, and I'm sure similar to what's available and what you're probably commonly using now in North America. So why don't I let you sort of mention or start talking about those, and then I'll see if there's a crossover, or you can let me know if there's a crossover.
Yeah, absolutely. So you made a point earlier as well. I just want to touch on just talking about how cost-effective chloramphenicol is, which, when I left Australia 2 years ago, you could pick up a tube of Chlor-Sig, which is like the ointment formulated variety, for $8 Australian or something.
Yeah, something right? Very cheap. Yeah, $6 to $8.
Which would be like $4 to $6 US for North American audience. So super, super cheap, and that's for like an 8-gram tube, like a conventional big tube. It's not nothing's that cheap over here. But I've only seen chloramphenicol once, and it's because veterinary care is a lot cheaper in Mexico. So there's people will take your advice and then say like, oh, that's really interesting. You think my dog has whatever condition, and then disappear south of the border, come back with a bunch of meds and be like, I've been trying this for 2 months. I'm no better off. Any ideas? And you're like, yeah, that surgery I recommended 2 months ago. That is what I recommend. But yeah, so that's the only time I've seen it. So it must be available in Mexico. But so for North America, in a dog, and in a cat, to be honest, and there's a little bit of controversy with this, and we'll touch on that as well. It's a nice digression. But yeah, based off availability, as Paul said, triple antibiotics are really popular over here as a prophylactic choice. So common formulations in an ointment is like neomycin, polymyxin, bacitracin. Common formulations for a drop is neomycin, polymyxin, gramycin. I use them interchangeably with, probably I'll reach for a drop if as you touched on, Paul, owner's preference, or if I've put a contact lens on, which for a superficial ulcer that has just occurred acutely, I'm scarcely doing that. It's more for other conditions I'm doing that. There's some studies that show cats maybe tolerate drops better than ointments. So if owners can apply the drops at that increased frequency, maybe cats benefit from that. There's a little bit of controversy, I guess, with using polymyxin in cats. There's a study that I'd have to have a look. It would be over 10 years old now. I'd say probably like closer to 12, 14 years. Looking at a bunch of anaphylactic events in cats, and basically they could tie quite a lot of them to cats that had been administered polymyxin within like a 30-minute period. A lot of those cats also had a bunch of other medications administered or other diagnostics administered, including sodium fluorescein, which is a known anaphylactic agent, admittedly when given intravenously, which is different to topically. But yeah, so it's not a home run that polymyxin is linked to anaphylaxis. And I guess like if you followed up enough cases, I'm sure you'd find like commonly used drugs like amoxiclav, given orally would cause anaphylaxis in some animals. So does that mean we should stop using this drug that's very, very safe and well tolerated by the majority? Yeah. So to me, the benefits of using it which is essentially it's very broad spectrum, very well tolerated. It's highly effective. It's cost effective. To me, this massively outweighs a single paper implicating it with anaphylactic events in animals that also received a bunch of other medications as well. How about you, Paul? Do you reach for something differently in a dog versus a cat, or any considerations with that?
It's a really good point. One thing our triple antibiotics are probably named something different in terms of the brand name, but contain, we've got the same sort of formulations as Ben, highlighted before. One thing that I would say, one reason that I do steer away from triple antibiotics in dogs, other than the cost of chloramphenicol, and I like just using one antibiotic in that case, whether or not that's true or not, whether or not that's reasonable or not, I don't know. There's nothing.
Man, I miss chloramphenicol. Chloramphenicol.
It's very easy. The other thing that I've had happen a couple of times, and Ben will recall, when I was an intern or early resident, or I was an intern, I think, and Ben was a resident, is that neomycin can sometimes sting dogs, a subset of dogs. And I was told that the ointment was stinging a dog by an owner, and I don't know why, but I proceeded to then put the ointment in to see, because I didn't believe the owner, and it did. And I still, to this day, I mean, I probably shouldn't be saying this on recording. If you're out there, I'm sorry. And it really stung. I don't feel like I've seen that occur since, but it is definitely reported, and I don't use much neomycin now, so that's probably why I don't see it. But is that something you see much, or?
So yeah, I mean, I remember that case, and it's like, yeah, when you see topical reactions to medications, and there's only been like 2 or 3 animals in my career that I've witnessed, it sticks with you, and you're like, this is not an over exaggeration or a misinterpretation of something else. You're like, 100%, this is a universal decree from this poor animal. Oh my God, do not put this in my eye. So I remember the case.
Yeah.
But yeah, I haven't seen it since being over here. I know neomycin's also been linked to like marginal blepharitis and stuff. I haven't seen that either, but I guess I'm aware of it, but I mean, thankfully not. Very blessed that's not the case, because It's a very, very useful medication to use, and yeah, of the medications available for North America, it is cheaper than most of the other alternatives.
In touching on cats, again, I just used Chlorcig or chloramphenicol as my first line. In saying that, to Ben's point, there are a lot of other clinicians at my practice who will continue to use triple antibiotics in cats and don't seem to have any issues. I see plenty of cats present on other triple antibiotics. If they're on that, I would just leave them on that. I'm not going to change it, provided it's appropriate and there's no infection or anything like that. In cats, the ointment versus drop thing is an interesting one. Depending on the cause of the ulcer, and this gets into a whole nother topic, but some cats really don't tolerate topical therapy well, or any therapy, right? Like some cats are just, it stresses them out. And as we know, feline herpes virus is probably one of the most common, if not the most common reason you might see a cat with a non-infected superficial ulcer. And in those cases, I do reach for ointments sometimes in order to reduce the frequency that the owner has to put the ointment in the eye. Whether that's right or wrong, I don't know. That's just something I've always sort of done. And it's cat dependent as well. Some cats are, really chilled and don't seem to be bothered by it. And if the owner's already doing drops and they say that the cat tolerates it well, then great. Other owners come in and say, putting an ointment in the cat is a big fiasco, and there's it's a 1 hour process of catching, towel wrapping, and then applying the medication to the cat. In those cases, I think reduction is a good thing. So I will often reach for ointments in those cases. But no, I mean, in Australia, it's very easy. If you've got a non-infected superficial or non-infected superficial ulcer, dog or a cat, chloramphenicol is going to be a very safe bet, and it's cheap.
Yeah, super reasonable. Which then I guess the natural progression of that is, I guess the opposite of non-infected is infected. So just for the sake of our audience, things that may imply infection. So you see like stromal involvement, so something's involved the next layer of the cornea. There's a couple of things that can do that. It's not infection, but certainly if the stroma is involved, your index of suspicion will be raised. If you see malacia, so the cornea, instead of being nice and solid, looks chalky and sort of this opalescent sort of snot-like consistency. Something I tell owners is I'm like, hey, like normal healing, the eye will go like red and blue, like, we're in America, God bless America. Yeah, that's good. Like red and blue is good. We love that. Other colors are bad. So like, if you see greens, you see yellows, ironically, the colors of my home country, Australia, but that is bad. That will imply that there's an infection present. So yeah, seeing these sort of things on the cornea, you'd be suspicious of an infection. How do you treat these, Paulie? Like if medication was how you were opting to treat it, what would you reach for antibiotic wise?
Yeah, really good question. Again, so basically, now that I think about it, I mean, there's two antibiotics that I prescribe probably 99.9% of the time. And when we're talking infected ulcers, I think we'll focus today on, I guess bacterial. We'll presume they're bacterial.
Good point.
There are other obviously, other causes, and we get into that in a later date, but let's assume bacterial.
Yeah, we'll skip amoebic keratitis today, I think.
Yeah, I think so. Although a very interesting topic.
Yeah.
And so for me, I'm reaching for, once I see infection, I'm reaching for a topical, and I'm reaching for fluoroquinolone. And the most common one that is used very, very frequently at my practice is ofloxacin, or brand names Ocuflox. And the only other thing that I'll perhaps do then in the case of an infection is, depending on how bad it is, I'll increase the frequency at which I'm applying the topical antibiotics, which is something one of our colleagues who's now in Boston, Dr. Will's big on. Sometimes even going up to, in the first few days, if the owners can, putting the drops in, alternating every hour. But you don't have to do that. 4 to 6 times a day is probably also sufficient, and what you'll read about. Now, I guess the next question is in an infected ulcer or stromal ulcer, can you then start to consider reaching for, systemic antibiotics? And that's something that I don't think that there's a strong consensus on, as far as I'm, far as I'm aware. Or
yeah, I guess my understanding of the consensus would be, as we know, oral antibiotics absorb systemically, so they have high serum concentrations. Many antibiotics, the ones that have been looked at and how well they passed into the tear film, and in a disease state, maybe there's slightly better penetration into the tear film, but overall they have pretty poor tear film penetration. So ultimately, you're guided by the vascularization of the cornea. If there's vascularization reaching the defect, maybe there's some benefit doing systemic antibiotics. But again, as we touched on earlier, like, you're weighing up the benefit of applying a drop of high concentration of a drug exactly where you need it to be, versus trying to give the entire dog an antibacterial dose of an antibiotic, hoping that some piddly little corneal vessel will deliver a sufficient dose. So yeah, I guess that's my thoughts, and I guess
I'm with you. I don't tend to do it. I see plenty of dogs or cats come in already on a course of oral antibiotics, and it's not like I write a scathing note back to the general practitioner or anything like that.
No, of course.
I don't, I would say that if you had to pick, the only times where I think a mistake has potentially been made, and this is, again, there are some compliance issues that, some dogs, it might be impossible to get a topical antibiotic in, and that presents a separate challenge that we'll talk about, I think, on another date. Otherwise, we'll be here all night. But I would always, if you can, I would always personally prefer to get the antibiotic in topically rather than systemically. Would be my.
And I guess the other point on that sort of just goes worthy of mentioning is in a non-disease state, the cornea is avascular tissue, and so that's kind of why it's different for a cornea to be poorly penetrated by antibiotics, whereas skin infection, bone infection, almost anything else, right? Like, there's systemic antibiotics. There's exceptions, obviously, like there's blood prostate barriers, blood brain barriers, whatever, but the majority of tissues can, through parenteral antibiotics, you can get sufficient concentrations, but the cornea is one of the exceptions for that reason.
So what are you reaching for, Ben, then? I've basically said that I've reduced the entire antimicrobial practice in a chloramphenicol and oxyflox. And even it real simple.
Yeah, well, I mean, look, and most of the time that there's nuance in everything, right? But most of the time that'll probably get you where you need to go. And yeah, I mean, I'm gonna make it just as equivalently simple. I mean, so triple antibiotic instead of your chloramphenicol, and then as an initial therapy, also reaching for ofloxacin. Typically, I'll grab a culture swab, and so 3 to 5 days is generally how long it takes for my local laboratory to return with an aerobic culture sample for bacteria. And so I actually put together this amazing graphic for a local vet talk, but anyway, I'll touch on the graphic in a second about this. But basically, this is, if you imagine WWE wrestling and you're in a tag team match, and you're just holding on for dear life by this infection. So your opponent's the infection, and you're getting strangled out, and you're basically reaching for the rope, and you're just reaching and reaching. That's your 3 to 5 day culture results to return, and then you can tag team in whatever antibiotic you actually need to help you at that time. So yeah, I'll see if, for the sake of this podcast, I'll see if I'm smart enough to edit in the graphic I made for this local vet talk.
Perfect.
Yeah, essentially for the initial treatment while waiting for these results to come back, yeah, that's my first of my tag team, and then 3 to 5 days if I got a tag team in a moxifloxacin, a cefazolin, or whatever the culture results say, that's when they're coming. But yeah, certainly it's a good place to start.
I will say you go.
No, you go.
I will say something interesting that I have point, but I think taking a culture is very, very sensible. I will say that occasionally when I see animals not respond to the sort of conventional therapy of a fluoroquinolone and then one of the other first line antibiotics that I spoke about, the few cases that I've had a really, really difficult time have been, I can only think of 3 off the top of my head, and this is very anecdotal, but they've been owners of the animal who have been in very unusual occupations where perhaps exposure to more resistant bugs would be common. And one of them that I'll always remember, this cat that literally had this infected ulcer that it was resistant to everything, and it took months and months to get on top of. And we tried cross-linking and everything, which we'll talk about another time. But the owner actually worked as I can't remember, I believe she was a nurse in a burns unit.
Oh wow!
And I couldn't help but think if there was some correlation there. Very anecdotal, but I just ignore that. That was just me.
Yeah, that's interesting.
Just going on a tangent. Now that we've spoken about, I guess, the antibiotics that we use and that we choose, should we sort of quickly touch on, what other adjunctive therapy we would prescribe, for a simple ulcer or infected ulcer?
Sure.
By way of anti-inflammatories, pain relief, atropine like mydriatics.
Sure.
Why don't you start there, Ben? What are you sort of commonly reaching for these days? I suspect it's probably the same as before, and I know, but I'd be interested to hear if your methodology's changed at all.
Yeah, maybe the smallest amount it's changed, but yeah, I think I'm going to bore you mostly poorly. I think we're going to be about 90% the same. But yeah, say a superficial non-infected ulcer in a dog, and it's just came in, and both of us are very thorough. We would have done Schirmer's, we would have done fluorescent and seen what the cornea around the ulcer's doing, whatever. Presuming everything else is normal, I'm probably only sending the dog home with prophylactic antibiotics topically, oral analgesia. If there's any hint of an epitheliopathy surrounding a lubricant, these days I'm very big on like hyaluronic acid based lubricants. I have been for a little while, but and yeah, that would probably be about it. What about you?
Yeah, I think it's pretty much the same. The only other thing I would add to that is a mydriatic in some cases, particularly if I'm seeing any sort of signs of a reflex uveitis.
Are you setting up home on that these days? Is that something you're doing? I might put it's a good point. I might put a single drop in at the time of consultation.
It's a good point. No, I probably put a drop in. For a number of reasons. One being, it's difficult to know how often you need to apply the atropine because you're applying it to effect, I guess. And, sometimes it lasts a few days. If there's more severe reflex uveitis, it might not be as long. So how often do you get them to do it? The other thing, I guess, that you've got to be mindful of if you do something like this is, breeds that are at risk for glaucoma. It can definitely sort of push the pressure over. So that's well reported. So I would definitely be taking the pressure before doing that. And if you're at all unsure, just don't worry about it. In terms of oral pain relief or analgesic, I guess I base it basically off of, whether there's any systemic comorbidities that need to be accounted for. So, non-steroidal anti-inflammatories, I think, good. There might be some ophthalmologists. In fact, I know there are some ophthalmologists out there who believe that they delay orally, they delay ulcer healing. I've never seen any evidence of that. But the times that I wouldn't reach for a non-steroidal, might be in an older patient or one with a history of, some, renal disease or something like that. And then I might reach for paracetamol, which I believe is called acetaminophen in the United States.
It is, mate. It is. It's not very commonly used over here, and you'll turn some heads from using it, or at least I did when I first moved here. But yeah, it is. It's very available. But yeah, just culturally or prescribing practice ways is just not very commonly done.
Right. Okay. Do you know of a specific reason why, or is it just?
Yeah, I think it's like, without getting into the weeds, I think a lot of it's to do with like FDA approval and how litigious places are and things like that.
Yeah,
would be my thoughts. It's also like, yeah, I think that's mainly why. Because I mean, like, if you Google acetaminophen dog, and that's your two key terms, you'll find 100 things on, Vin and on Google of like, oh my goodness, my 5-pound dog ate a whole box of acetaminophen and now it's in liver failure. And, like, if you eat a whole box of amoxiclav, your 5-pound dog's also going to be at a toxic dose.
Yeah.
So, like, it's, we know it's all dose dependent, and it's a really effective drug. I think it's a great drug. I still use it for select cases, but at least in my experience, the local veterinary culture of using it as an adjunctive analgesic, it's not very commonly done. And so, yeah, trying to not be viewed as the crazy foreigner, I've certainly mellowed out my prescribing practice for it, but I still think it's a great drug.
But I think it touches on a really good point, which is, at the end of the day, working as a specialist or a general practitioner, you're working collaboratively, and if there is an option that everyone's comfortable with and it's going to achieve the same thing, then I think why not? Because the last thing you want is your referring practice to not be so comfortable with the drug that's being used or familiar with it. And so I think it's if I were you, if I were in your circumstances, I'd probably move away from it as well, because there's plenty of good alternatives.
Yeah, and to your point, like it was alerted to me from really well-meaning people, just being like, oh, hey, just so you know, like, this is a toxic drug, and like, dang. Yeah, like, at the dose I'm using it, it's not, but I appreciate you coming from a good place, and obviously, to your point, like, it's a collaborative community, and we're all working together to achieve the same goal, to try and help heal this patient. So if people feel offside or uncomfortable with my treatment plan just from lack of familiarity, then the easier way to do it is to change my treatment plan.
Yeah, provided it's achieving a similar outcome or the same outcome.
Sure.
One thing I will touch on there, just talking toxicity, I'm speaking in case anyone's listening going, this guy's absolutely crazy. Obviously not in cats. Definitely never in cats.
Good point.
I'm talking strictly about dogs with the paracetamol, the acetaminophen. That I know is absolutely never do that. No, we don't do that in Australia, I promise. But
good point.
Okay, say you get a case, Ben, where a non-steroidal might not be appropriate. What are you reaching for then these days as an alternative?
Yeah, in a dog, again, I still do reach for acetaminophen, just not as frequently. But yeah, gabapentin, I'm less convinced it's an effective analgesic on its own, but it is very safe. For dogs with multiple comorbidities, if I don't have a ton of options, I think it's nice. There's been patients where even in hospital, I've given them a single shot of buprenorphine just to at least start the analgesic journey, and then send them out the door as a discharged patient with oral medications, most likely gabapentin, just because it is safe. There's a lot of concern with discharging animals home with restricted medications here. So, as you and I both have experience using tapentadol, which is like the pro-drug of tramadol. So, it's at the metabolite that, my understanding, not an anesthesiologist, my understanding is it's, at the metabolite that is effective in dogs. Like, they don't have to metabolize tramadol into tapentadol. It's the tapentadol that's the effective drug, is my understanding. Loved using that in Australia. I think there's a lot of concern sending clients home with it over here, is my understanding. So that's not done as frequently.
Yeah, I've got to say I don't often reach for tapentadol. I think the few cases that I would do it for would be like a really big surgery or something. But I do have some concerns about, as you said, it's a scheduled drug, and the responsibilities surrounding that. I think one thing, that I do sometimes is, if I'm out of options for an effective oral pain relief due to comorbidities, I send the dog home on atropine every other day, like every 48 hours or something. Now, there are some times where that isn't recommended. I mentioned, glaucoma previously, or the risk of glaucoma. Another scenario might be an underlying, heart condition. If you're really up against it, where there is no good therapeutic option and for pain relief, and I can't think of any times that this has been the case, to be honest, but let's just say hypothetically, you were in that scenario, then a contact lens actually provides, a fair amount of, I believe, analgesia. And I'm basing that off the fact that whenever we perform a diamond burr or a grid keratotomy, I'll always put a contact lens in. And invariably, if I get a phone call early that the dog's gone from painful to not painful to very painful all of a sudden again, 9 times out of 10, the contact lens has fallen out. So I do believe, based off what I've seen, and I don't know if there's any studies to sort of substantiate this, but I do think it provides, some degree of analgesia. The difficulty is, whether or not it stays in.
In humans, it certainly has been established too. Like, it's an analgesic treatment for humans, which actually leads me on to another point. I've noticed that neither of us mentioned that we use topical non-steroidals as analgesia. It's something that I didn't see very commonly in Australia, but it's really common over here. That on corneal ulcers, every dog will get diclofenac or ketorolac, and the benefit, like, purportedly on the prescription label, is like, hey, it's a pain relief. Is that something you've seen? Like, I certainly wasn't seeing it 2 years ago. Is that finding its way?
No.
And if not, yeah. Do you want to touch on why we don't do that typically, or?
I think, the reason that I steer clear of it is the worry about potentially development of a secondary infection, having an anti-inflammatory locally there. I believe there is a paper that touched on this, and I think I'll have.
It was Dr. Josts with indolent ulcers.
And did she find an increased infection rate?
All good. Yeah, I think it was decreased healing time. Oh, sorry, like prolonged healing time.
That's right, delayed healing. So look, it's not something that I've been typically in the practice of doing. And that's why delayed healing, risk of infection, would be the concerns that go through my head. But
no benefit. Like, there's been some Cochet-Binet studies in how sensitive is your cornea after applying it. Like in our species with less sensitive corneas in humans and different receptors at different sites in the cornea, there's no evidence that it's helping for that benefit. So yeah, in the absence of benefit and some evidence of it hindering, at least, yeah, that's sort of the thought.
Yeah, I think that's a reasonable one. The other, actually, now that we're talking about topical anti-inflammatories, an interesting paper that I did come across during my board studies, I believe it was specific to ketorolac, or they might have looked at a few, but they actually did find that gastric ulcer application, topical application could predispose did carry the risk of gastric ulceration as well. So if you are steering away from an oral non-steroidal, and reaching for a topical for that reason, then perhaps that's something to consider. I have actually seen a case where it didn't go and get the scope or anything, but the dog developed nausea and vomiting immediately after starting a topical non-steroidal. And when I stopped the topical non-steroidal, it improved. And so,
man, I think it's real. I think it's legitimate. I mean, so it's funny you mentioned that paper. So I share an office with shout out Dr. Posakonis. I share an office with an internal medic who did a residency at Iowa, which is where that paper came from. It's funny you mentioned that, because in the last week we had a dog in town who presented to the medicine department with a gastric perforation, and the only medication that animal was on was from it was appropriately dispensed, like it was, an indicated use of topical ketorolac. It was just the world's most unlucky dog and the world's most unlucky prescribing vet. And basically, the medicine team were talking, and they pulled up that paper and were asking me about it. So I reread it because it's certainly not at the forefront of my mind. But they found incidence of ulceration at similar rates if used topically than for orally. They found that they compared ketorolac and diclofenac, and ketorolac seems to be much more culpable than diclofenac. So I guess maybe that's a tidbit. If you feel like you need to use it, maybe reach for diclofenac as opposed to ketorolac. But yeah, so anyway, that they literally suspected this gastric perf from topical ketorolac, and I think it was only using BID usage as well. Admittedly in both eyes, so I guess the dog, a very small dog, receiving 4 drops a day, but it's not crazy doses.
It's something I've done many, many times. So it's really unlucky. That paper, the other thing it got me thinking about, and I think we'll summarize and wrap up, because otherwise we'll go for ages.
Yeah, we could be here forever. Yeah.
But that paper got me thinking about how I used to be, I guess, not particularly careful, or not careful is not. I didn't used to consider that risk, and I never used to consider, or I didn't spend as much time thinking about the risk of, perhaps you might have a dog that's on, maybe it's had, it's got uveitis or something, and it might be on an oral non-steroidal, and then you might apply it topically as well. And I've started to think a lot more about that now based on those studies, because, I do worry. But yeah, no, really good.
Yeah, especially,
small
animal. Yeah. We
So I think,
for the sake of time, we might have to start wrapping her up. But I guess in summary, the only other thing I think worth touching on is, because I know we both mentioned what we'd use as a first line, I guess why we wouldn't reach for fluoroquinolones as a first line, because we both would use it as a second line. I guess for me personally, it's, there's some studies that show animals who've been on topical fluoroquinolones throughout life, their likelihood to get resistant ulcers to fluoroquinolones subsequently, both in native bacteria, but also at times of disease, is a lot higher. So that's probably an important one to touch on. But have you got more to add on that, Paul, or the same thoughts?
No, I think it's the same thoughts. And just thinking back to, what you're trying to cover in terms of spectrum, what you're targeting, it's good to save those big guns for when you really need them. In saying that, if you, let's say you're listening and you're like, oh gosh, I've put a dog on topical, fluoroquinolones before, or a cat, and I wasn't sure if the ulcer was infected or it was an ulcer that wasn't infected, it's probably not something I'd continue going forward. I'd save those for when you're worried about infection, but don't beat yourself up because it's very unlikely that you've caused any sort of permanent harm. But no, yeah, that's probably, but it's the same justification as you. I just, yeah, I've always treated it as a second line antimicrobial.
Yeah, perfect. Well, thank you for joining me today, Paul, and thank you everyone for listening in. So that's probably my parents, your parents. That probably sums up the entire listening audience.
No. Actually, Ben is being very modest here because I've had we've both separately had two very, very esteemed colleagues from UC Davis who have both reached out and said that they've listened. So shout out to those two listeners. You know exactly who you are. Thank you for joining us. So we've got 4 now, which is fantastic.
Terrific.
Oh.
Yeah. At my wedding, mate, both of my parents are going to beeline straight to you and ask for an autograph or something. They'd be number 1 and 2 listeners, mate. So you'll be hot property.
I'm excited. That's why I've been doing this. I've been gearing up for the wedding. We're going to have to ramp up a couple of special editions before then. And yeah,
I might have to hire security, mate, just to
just
stop you from being mobbed.
Oh, all right, mate. Well, have a lovely night, and I'll see you next week.
Okay, gotcha, mate.